In a way, everything I thought I knew about sepsis, I'm probably wrong about. And I think that's probably the most fascinating part of working with data scientists and machine learning, because we only see what's in front of us and we don't always put all the pieces together. But in machine learning, the machines look for patterns and things. And so when you take 300,000 ED records and look for patients who had sepsis and look for what those patients looked like when they presented to the emergency department, it goes far beyond what we currently look for at triage, which is the source of infection and two source vitals, because that's really all the information we have at that point.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thank you for joining me on the podcast. As always, don't forget to subscribe to make sure you don't miss an episode, and make sure that you're following us on both Facebook and Instagram. I have a great episode planned for you today. Back in episode 28, I did an interview with my friend Deena Brecher and her company, Mednition. Deena talked about a program called KATE, which is machine learning brought to the triage chair. That software in real time will tell a nurse whether or not the triage category that they selected matches what the machine would have suggested. If it matches, then great, no message, no nothing. If it doesn't match, then the nurse would get a quick message saying, hey, just double check this, but ultimately the decision would be left up to the nurse. Well, I'm visiting with Deena again, and it turns out that not only does KATE know ESI, but KATE knows sepsis, and she knows it well. You are going to be blown away by the data in this episode. I hope you enjoyed this episode with my friend Deena Brecher from Mednition. Hey Deena, let's talk about KATE again. It sounds like you guys at Mednition have taught KATE a few new tricks.
It's really, when you sit back and think about it, unbelievable in the sense that we took advantage of the time for COVID to do some more research and development and really focus on sepsis. And I'm kind of glad we got pushed a little bit, because I just finished analyzing the data for the first 6 weeks this morning. So, yeah. So, it's even hard to describe. In a way, everything I thought I knew about sepsis, I'm probably wrong about.
Really?
Yeah. And I think that's probably the most fascinating part of working with data scientists and machine learning, because we only see what's in front of us and we don't always put all the pieces together. Yeah. But in machine learning, the machines look for patterns and things. And so when you take 300,000 ED records and look for patients who had sepsis and look for what those patients looked like when they presented to the emergency department, it goes far beyond what we currently look for at triage, which is the source of infection and two source vitals, because that's really all the information we have at that point.
Yeah, it's the best we can get.
Yeah. So to be able to provide ED nurses a tool to recognize patients that potentially have sepsis accurately as soon as you sign your triage note has made much more of an impact than I expected.
Wow.
Yeah.
How many? And we'll get into this, because I think there's I have so many questions. I don't want to start in the middle. That's where I would start. If it was up to me, I'd just start right in the middle and be like, okay, tell me how. Why did all this happen? But given what you know, so you did a retrospective look at all those
So the way machine learning works is it's a de-identified data set. In this case, I think it was closer to 225,000 ED records that had triage information and then a diagnosis. And so our lead data scientist takes those de-identified records and works to build a machine learning model to identify patients with sepsis. And the ins and outs and how that works, not the right person to explain that. Can get you the right person to explain that. But, it took us, Kate took 7 years because we had to build a lot of the underlying infrastructure and technology to be able to make real-time, clinically accurate decisions. Sepsis took us about 6 months. Yeah, because again, once we're able to de-identify records on the fly and read and understand everything in the notes, including what free text, it's just building and tuning the model itself. And so there are about 3,200 patients that had sepsis in that data set of about 225,000
Now,
records.
is most of these records are all of these records from one hospital?
No, they're from 3 different hospitals.
Okay. Nice. That's exciting.
Yeah.
That's exciting.
Yeah. And
the more you get, the easier it is to see patterns. Right?
Correct. And the more accurate we can become. Imagine looking at patterns over 1 million patient records. I mean, you can't, from a human perspective, you can't do it. You could spend your lifetime trying. But from a machine learning perspective, it's just tremendous. And I think as a clinician involved in the process, the hardest thing to be comfortable with, which I am, but it was just a little disconcerting in the beginning, is to be reviewing records that don't meet the typical sepsis criteria at triage, right? Source of infection and 2 source vitals. And find out that those patients had sepsis. So as clinicians, we looked at 100 different records. A couple of us looked at the same 100 records. Half of them had sepsis, half of them didn't. We did not do well. We did better than the overall accuracy for the nurses in those patients, but the nurses weren't looking for sepsis. They were looking for triage accuracy. And we did better than source of infection and 2 source vitals, but Kate sepsis did so much better than we did. Yeah. And so you have to be okay with understanding that most of our research has been based on a couple hundred, maybe 1,000 cases, or their meta-analysis of multiple different studies.
But all still pretty small subset.
Correct.
Now you're going to take that.
Yeah. And so to see what the model considers to be important and what those clinical features are, and some of them, we were like, wow, I never would have taken that into consideration when I'm looking at a patient at triage if they have sepsis or not. Like that would never have crossed my mind because it's not what I've been taught to look for. And so being able to say, okay, you know what? We know these are correct because we can match them to the diagnosis. So we have to be okay with using technology to help us make better decisions and help us improve the safety of the care that we provide. And that, it's like, not that the machines are taking over the world, and nurses are incredibly important because without the assessment information, without the documentation, none of this would be possible.
It's all for
right.
naught. Like, you can have all the technology in the world, but if you chart patient fine, resting quietly and comfortably, that's it.
That's it, right? Yeah, there's not much to go on. Yeah. So it's those are the things that I didn't think about before we got started, and then once we started, I think the first time that Alex, our lead data scientist, presented the results of we call them runs of data to the clinical team, we all sat there with our mouths open, like, wow, Yeah. In a good way.
Like
in a really good way.
Holy crap, this could be something.
Mm-hmm.
Like this could change the game.
Right. And then how do you build the confidence of the nurses who are using the tool and the physicians to when they get that message, even if it's a patient they're not sure or wouldn't have normally considered.
That they're not like bullshit. Like whatever,
yeah,
it's fine.
exactly.
The computer says you have sepsis. I don't think you do. 24 hours later, you're like, who knew? Who knew?
Yep.
Kate knew. Kate knew.
Yep. Yeah. So it's that those are all important things, because one, we have to be able to recognize that we're all human.
Yeah.
We all make mistakes, and we only have the knowledge that we've gained along the way.
Yeah.
And there are so many more things to learn.
Yeah.
And that's why I love the ER, because there's always something to learn.
Something to learn.
And then to be able to build that trust that, this is clinically accurate, and the outcomes that we've seen so far have been tremendous. And, we can't look at sepsis outcomes as far as mortality, because you need a couple of years worth of data to do that. But we could look at timeliness of care.
Mm. When you think about, one of the things I always think about with sepsis is when you think about from recognition to antibiotic start time, that's a real number. That's a real number that if you can shorten that time
by half,
that's huge. That's game changing.
Yep. That's what we were able to do in the first 6 weeks, is by half.
Holy shit.
Twice as many patients correctly identified at triage, and the recognition to antibiotic time cut in half.
Holy cow. That's real day. When does this publish?
Well, the press release is probably going to come out Wednesday.
Oh my.
And the more data that we get, obviously we want to continue. We want to be able to differentiate between sepsis and severe sepsis and septic shock, and continue as patients become or start to look like in their ED visit that they could have sepsis. Those are all things that will come with the data.
Wow.
So we started at the front door.
Holy cow. That's super cool.
Yeah.
To fill in the audience, we kind of started in the middle, which is not uncommon for my podcast. So that's okay. But we've done a previous episode that hopefully they're going to go back and listen. In that episode, we talked about Kate and what Kate is, and in a simplest, dumb Kevin who's not a computer guy.
So Kate works in the background at triage. Nurses do their assessment like they normally do. They document like they normally do. And when they electronically sign their triage form, we take all that information, we run it through our model called Kate. And if there's a disagreement between the acuity level that the nurse assigned and the acuity level that Kate predicted, we send the nurse a message. Comes about 5 seconds after they sign their note. And the idea is to kind of stop and take a minute and consider the information in that message critically and apply it to the patient that's in front of them. The nurse has the ultimate decision-making authority because the patient is in front of them. And so Kate has been live at Adventist Health White Memorial in LA for almost a year and a half now. About 95,000 triage, not 95,000 patients have been triaged since we started.
With Kate.
Mm-hmm.
What's the feedback been from that hospital?
It's been tremendous. The feedback's been tremendous. They're very engaged in getting the messages. If there's a question or a comment, they're great about reaching out. We do some research. Example, this is related to sepsis, but we got a message from a nurse about a patient. We had discussed pelvic pain, believe it or not, as a source of infection previously. We'd done a whole lot of data analysis, but now here's an example related to sepsis instead of triage acuity. And so we brought all the data to the clinical team. We reviewed all of the data again, and we agreed that the decision we made the first time was correct. But that's how important that feedback is to us. We do take all of it, we learn from it, and then we make model improvements based on that feedback.
I mean,
so we're getting ready for a new update pretty soon, a couple weeks.
The QI capabilities and the data, being able to make meaningful use of just data that you're collecting, that every hospital is collecting thousands of data points every minute, thousands of data points every minute, and it's just not going anywhere. Like,
and asking nurses to click a box to say they did something because they have no way of looking through the chart electronically to see if it was done or not.
Yeah.
And all that goes away.
Boy, that could be a game changer.
All that goes away when you're using Kate.
Be like hey, we automatically clicked that because in your note you said you did a skin assessment. Check.
Yes.
Done.
But you can document where it feels most appropriate and not have to manage hard stops so that you make sure you fill out something that you've already documented somewhere else, but if you don't document it in that one place, it doesn't count. But we want to make sure that we are committed to clinical accuracy. We're committed to making sure that you don't have to change your workflow. You don't have to change anything that you're already doing because we don't want to be in your way.
Yeah.
And the messages have to be clinically significant, and they have to arrive when the patient's in front of you. And so, we'll see how it goes.
Now, is the only place currently with Kate's current iteration, is triage the only place that Kate gives feedback?
Right now, yes.
Is that going to change?
Yes.
Okay.
Yeah. Again, it's about data, right? Building a new product is about data. And so for us, we have a long list of things that we want to do. And every time we talk to another hospital, we get more ideas. So ultimately, our ultimate goal is that Kate will message throughout the patient's entire day through the ED and through the inpatient side as well.
That'd be cool.
Yeah.
That'd be cool. It'd be like, hey, sepsis flag. I don't know if you noticed this, but Miss Deena in room 21 just started spiking a temp, and that might be the first sign of sepsis.
Yep. And what is that number, by the way? Those are the things we get to look at from the data.
Yeah.
Is it 38 or is it lower than that? Or is it higher than that? And does it matter what age you are? And all of those things. Again, we put everybody in one box and say, especially at triage, source of infection and two source vital signs. And it's all we got right now.
Yeah. We've
got new stuff, but everybody else has just that, and you do the best you can with that. And we know that, half the time the patients that you identify that way have sepsis, and the other half they don't. But you're also missing half the patients that come in the door that you could identify at triage, because maybe they don't have two SIRS vitals, maybe they have one SIRS vital, maybe they have 0 SIRS vital, but they're still sepsis.
And see that's the part that scares me a little bit, because everyone's got a story. Everyone's got a story of a patient that came in, seemed okay. Then, an hour later, you're like, holy shit, you're in sepsis. And you're like, okay, we got to figure this out. We got to take care of this patient. But now, based on all new information, the information we have now that we were completely blind to, like that, I think that scares me more than anything. It's you're like going, and if that's something that the computer could have figured out through computer learning, if that's something Kate could have figured out an hour, 2 hours before I did, that's 2 hours closer to antibiotics and start working towards bringing that person back from that brink that they're going to, but we don't even know they're going.
Right. And that's our goal.
Huge. That's huge. That can't be understated. I mean, that's just...
we know that sepsis is a killer. We know that not every patient can check the boxes at triage. I wonder, with point of care lactate at triage, are we not ignoring patients, but are we skipping over patients because their lactate is 1.4? But that's one piece of information.
Yeah.
So we have a lot more to learn, a whole lot more to learn. This was an opportunity to help the team at White improve their recognition to antibiotic time. They were having, they were doing like 30 to 40% of the time, and they have a 1 hour bundle target there. But if you're only recognizing 30 to 40% of the patients at the door, you're not going to be able to do much better than that. But if we can help you identify 86% of the patients at the door, then you're going to be.
Now hold on, because 30 to 40 to 80.
Yeah, to 80.
That's
a little over
game
80.
changer.
Yeah. Yep. So they missed about half. They missed about half of their patients before. And when I say that, it's not a reflection of the nurses and the providers.
Every nurse has been there. Every nurse has been there.
Right. It's patients who met the criteria of source of infection and Schuster's vital signs represented about half the patients that were in that ER that had sepsis.
And Kate picked up another 40%.
30%, yeah.
30% accurately.
Mm-hmm.
That's a big deal.
It's tremendous. We had a lot of excitement when we started using Kate. The excitement that we have now amongst the nurses about Kate sepsis it kind of blows me out of the water. You know how when you implement something new, you have people who wholeheartedly grab onto it and run with it.
100%.
And then you have people that dig their heels in and absolutely not. They figure it's going to go away soon, so why should I bother? And then you've got everybody in the middle.
Yep. Yeah.
So
I'm usually one of those middle guys.
Yeah,
I'll be honest.
Kind of see what happens, and yeah, that's understandable. Most people are, and in order for change to work, you have to have the middle ground.
But think how many things that are like that though, like point of care lactate. Like I was like, point of care lactate. Okay, a brand new lab. It's gonna change everything, and you're like going, sure will. It is. I mean, I remember when I went to nursing school, we never even talked about point of care. We never talked about lactate. I remember
rotavirus vaccine.
Right?
Yeah.
Yeah, I mean, there's a million things. There's a million examples that everybody has of things that you're like, oh yeah, there's that. And then you're like, oh, that mattered.
So for me, feedback is really important. It's the feedback from the laggards, the feedback from the ones that dug their heels in that helps me see where we're at. And so I will say a couple weeks after we started with Kate sepsis, one of those nurses pulled their assistant nurse manager aside and said, first of all, this sepsis screening is so much better than what we were using before. And second, I had to take a triage test at another hospital and I got 100%, and that's because of Kate.
How cool is
that? So that's like, okay, excellent. It's meaningful. It helps. It's making us all be better nurses. It's helping us make better decisions for our patients. It's helping decrease preventable errors. All of those things that were on the table as what we wanted, why we're doing what we're doing. And so to be able to be on a call with the charge nurses, that was last week, and for me to kind of be reporting the statistics where they're at, and for them to just start cheering, 3 days in a row, no fallout. So nobody who had a greater than 60-minute recognition to antibiotic time, and how excited that they get over it, because they want to do as the best job that they can.
Have they been tracking it, or are you guys tracking it?
So, understandably, being a leader in the ED right now is a challenge. There's never time on a normal day, but right now,
in a good week, it's challenging.
Correct. So I'm helping with the data. Yeah, I'm helping with the data a little bit, but we review every case that every time Kate sends a message about sepsis, as in every time there's a patient with sepsis that we don't catch at triage, we review those as well.
Wow.
And from a Mednition, and I review this with the ED leadership team, from a Mednition perspective, we're looking at every false positive, every false negative, and what can we learn from those and how can we improve the model. So the way the corporate measure for their antibiotic time is for severe sepsis and septic shock. We're looking at anybody with a sepsis diagnosis, and that's what we did beforehand. So, yeah.
That's pretty exciting.
To look at the data to understand that their recognition to antibiotic time, which for them is triage, was about 42 minutes median. And now, since the 17th of July, so for about 6 weeks, they are at 20 minutes median.
Cut in half.
Yeah.
Cut in half. Recognition, and this can't be understated. I mean, so you're talking a 50% reduction in time from patient presentation. We'll just say patient presentation, calling it triage, to antibiotics delivered.
Correct.
A 50%. I mean, that could be life-changing, truly, literally, absolutely life-changing in a lot of people.
Yep. And
not always. I mean, a lot of those people are going to be fine either way.
And they didn't change anything. So they didn't change anything at triage. There's no labs involved. It is purely based on what the nurse documents at triage and any history information that's in the record. That's the decision being made. Obviously, labs and other things would make that prediction more accurate, but that's not what you have at the front door. And so we want to pick out as many of those patients correctly as we can at the front door.
So is Kate just looking at, Kate's not just looking at the triage note, it's looking at the medical record.
Anything you have access to at triage that gets sent to us. So medical history, surgical history, social history, things that are kind of reports in your triage note that you could look at, but you may not, you don't have time. Or they're here for a laceration and, their 7-page medical history may not be relevant to the complaint that they have right now. So that comes at White, all of that information comes over. So any history that's documented, medical, social, surgical history comes over. And so we use that information.
Now, do you have access? Okay, so I come into triage to this organization. I come in, never been there before. They have no idea they don't know anything about me. They sit down, they do a triage. I tell them my history is X, Y, and Z. So they now have X, Y, and Z to add into the fold. And then Kate's gonna predict my triage acuity. Let's not understate what Kate originally does, right? Which is pretty cool too, right? So in addition to all that, Kate now has the potential to say, oh, and by the way, you might be septic.
Correct. And we do it at the same time. So the nurse will get one message. It may be an acuity mismatch and sepsis. It may just be sepsis. When we started, we didn't message on matches because that's just noise. And we want to.
If I think it's a C and Kate thinks it's a C, no message.
Correct.
It's good.
So now with sepsis, if there is a match, we still send a message that says it's sepsis.
Okay. But that could very well be what the nurse is thinking anyway.
Yep. And the whole idea of sending this message is we're going to help you pick out the patients at the door, and then that gives you the opportunity to improve your processes to be able to get that patient what they need. And so we worked with the team at White to, so this is how accurate we are identifying these patients. So every time they get a message, what is going to happen? And so they had been trying a whole bunch of different things prior to, and then picked their process. And they do start a sepsis alert for every sepsis message they get from Kate. And then any other patients that the nurse or anybody up front or at any time during their visit they feel meets or could potentially be septic.
Okay. Now, okay, so Kate's looking at the triage note.
Mm-hmm.
Kate's looking at the triage note. Kate's looking at the information that we have available. So again, like I go in there for the first time. I've never been in that organization before. You put in my history, my vital signs, my physiologic stuff, and it's going to come up with a triage accuracy and a hey, maybe sepsis flag.
Right.
Now, once I get brought to the back, and the next nurse sits down, the next nurse types up even more information about me and says, "Oh, geez, Kevin, you didn't tell us that you are a chronic kidney failure patient and that you're super sick and that,
They're on 40 different medications." Yeah.
You're like, not just those 3, but these 4 more medications. Does that then get put into Kate too?
So it depends, I guess, is my best answer. It really, at what point does triage end and plan of care start, right? And so in my experience, it's been when the provider sees the patient and starts the plan of care. Then it's not about acuity, it's about a change in condition of the patient based on the physiologic data or labs and all that kind of stuff. So in a process where the door to provider time is an hour, Kate would continue to send messages every time, if needed, every time the record got updated, up until whatever time the organization wants to stop. So, our recommendation is provider time, or if they're in the case of white, their provider is at triage. So we actually looked at the data and we said, okay, you're 90% of the time your team finishes or sends another update message in 4 minutes. And then that's it. It stops. And 95% of the time it's 8 minutes. And, and so, or not 95%, the 95th percentile. Sorry, I said that wrong. And so we looked at that and said, okay, with that information, we are going to send messages until 30 minutes past their first note. The first time they sign the note, right? And that's just based on their process. It did make sense to stop when the provider saw the patient. So they do sometimes 20 minutes later, and they added a blood glucose, and that changes the prediction.
And does Kate pick that up or no? Kate's done by then.
Nope. At 20 minutes, Kate still gets it.
Oh, gotcha.
Yeah, most of the time it happens within 10. Most of the time, if they, you have the patient in front of you, you start your note. Okay, now I'm going to get a glucose. I'm going to do your vital signs, and then and you're talking to me, and then I turn around and I finish typing everything, and then I sign my note again. Yeah. It's fun because I have a really bizarre definition to watch the progression of not only how we add information to the record, because we can see all that, but what happens when Kate sends a message. So there are a lot of mistakes that happen in the medical record, mostly typos and numbers being reversed and whatnot. So what'll happen is, I'm sorry?
Can Kate figure that out?
Yeah. So Kate knows when a vital, one vital or 2 vitals are completely
not compatible with life.
Correct. Kate will predict based on the vital signs entered. So let's say you enter a respiratory rate of 110 because that was the systolic pressure. Kate will predict a 1. And you'll say, well, why is Kate predicting 1? And then you look because we send vital signs back. That's why. And you go and fix that. So the providers have said that they used to have to chase nurses down to repeat abnormal vital signs that are clearly not correct in order to discharge a patient. And they almost never have to do that anymore because they're getting corrected at triage because they're generating a prediction that doesn't match what the nurse is putting in because they're errors. The same with triaging a patient with a laceration and accidentally clicking homicidal. They get a message that says, this should be a 2 because this patient is homicidal. And they could go back and correct that.
Well, homicidal, huh?
Yeah, exactly. And they go back and in the beginning, I would get these messages that would say, hey, Kate predicted this and it doesn't make any sense. And then I'd go back and say, that's because you documented this. You documented a GCS of 3, but the patient was awake and alert. And, conflicting documentation is a challenge. One day we want to help tackle that too. But
good luck with that.
Being in a startup, we got to be, we're laser focused on supporting nurses at triage right now. And as we grow, lots of things that, imagine if we sent you a message that said, based on what's here, and this is obviously not what the message would say, you might ask these other questions. So, if, you document the patient came in for shortness of breath and they left their inhaler in the car and there's no assessment whatsoever, the patient's respiratory status. Oh yeah, I should document. Anyway, so like I said, we have a long list of things we'd like to help with.
That'd be my problem working with a technology tool like that. I'd be like, and then I wanted to do this, and then I wanted to do that. When in reality, you're like, let's just get triage laser focused.
And we do the same thing. We'll be in a clinical meeting and we'll be like, wow, it'd be really cool to do this, this, and this. And the engineering team will look, it's on the list. Not right now, but it's on the list. And sepsis came early because we had time because of COVID. As hospitals were really working on making sure that their teams were safe and how to figure out how to care for these patients, we took that time and said, okay, well, how can we contribute to that? Well, if we can help pick out these patients who have sepsis at triage, then, that takes some of the stress off the clinical team, knowing that there's another, again, that angel on your shoulder going, hey, you might want to take a look at this. And Kate's not perfect in triage accuracy, and Kate's not perfect in sepsis either. But Kate gets better every single time we make a change in the model, and we won't put a new model out unless there's incremental improvements. And so we do that about once a month. We'll put a new model out. Yeah. We're getting, I said, we're getting ready to do one now. Yeah. So,
super cool.
To look at, and I have all my data on my board, so I wouldn't forget any of the important statistics as well. I have a 6-foot whiteboard in my office.
Awesome.
Yeah. And so, we, in the kind of data we did directly before we started, the team was about 65% getting antibiotics within that hour. And now they're 84%. And like I said, the time is cut in half. The median time was cut in half, and the average went from 57 minutes to 35. So they're doing a fantastic.
So wait, let me just make sure I got this right. So accuracy went from 65 to 84?
Not accuracy, but antibiotic delivery.
Oh, antibiotic delivery. And then the average went from 57 minutes
to 35. Yeah.
Like almost
half, yeah. Mm-hmm.
What's been the most significant improvement you've seen with Kate? And like what number just blows your mind?
Well, it all does. I mean, correctly identifying 50% more patients blows my mind.
That's mind-blowing.
Yeah. And it really is because those patients didn't meet the definition. They don't meet the definition. They have a source of infection, but they may not have any SIRS vital signs. They may have one SIRS vital sign. And so when you give a nurse a tool to use in triage, and that tool is not very sensitive or specific for sepsis, it is great for picking out patients who need to be admitted. But it's not necessarily great at identifying sepsis correctly. And that's how we're being measured, right? And the idea is the sooner that you can start care, the better the outcome that patient should have. And so, again, we can say at triage, no labs, no nothing. Yes, this patient likely has sepsis. And then from there, the team says, okay, we're going to get this patient evaluated. We're going to get the antibiotics ordered, get labs ordered. We're going to get them administered, and we're going to go on from there.
This may be kind of a dumb thing. This is just Kevin's dumb thinking. So have you guys done any kind of tally sheet where you're like, okay, like out of 30 patients today, or out of every patient today, like just looking at a patient, if you said, okay, they have sepsis, and you put a little hash mark, say, okay, I got this one for sepsis. And Kate says, okay, I got this one. And Kate says, oh, and this one, Kevin that came in with his diabetic foot, he's septic too. And you're like, I don't think so. Kate's like, okay. Have you guys done like a tally sheet? Like,
I have
machine?
Every day. Yes, I have every day how many patients triggered Kate's sepsis model, how many of them met the criteria for source of infection and two-source vital. So in other words, would they have been caught before?
Because that's all we're looking at, really.
Right.
Really.
So in 6 weeks, we identified 43 more patients with sepsis than they would have in their old process.
In 6 weeks?
Mm-hmm.
43?
They had 157 patients with sepsis in that time.
Like what percentage
of patients that had sepsis did we identify without that they wouldn't have caught before?
Yes.
Almost a third. So Kate sepsis has an 82% true positive rate.
That's huge.
In the same time period, source of infection and two-source vitals measured at a 55% true positive rate.
55%? Or two sears and source?
And source of infection, correct.
And that's the gold standard.
Yeah. And the gold standard for right now at triage with no lab, yes.
Wow. That's incredible.
And if that's my family member or me sitting in that chair at triage, is that good enough? It's not good enough for me. It's not good enough for any of the clinicians that I work with. We want to do better. We want to help identify these patients as early as possible. It's not good for the engineering team at all. And all the data science and statistical fantastic, amazing brains that I get to work with, we all say the same thing. If that was me in the chair, I want you to be able to be more accurate. And that's what Kate Sepsis is able to do. It's able to say, if Kate says this patient has sepsis, 82% of the time, Kate is going to be right.
Compared to 45 to 55.
Right. Or in that same time frame, it was 55%. Yeah.
55 based on Sears criteria.
Mm-hmm. Yep.
That's big.
And the best part is you don't have to do anything different.
Deena, I can't wait to see how this all turns out. This is absolutely incredible. I can't thank you enough for sharing this with my audience. Please come back soon and let us know how it's going.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.